I'll be discussing incidental findings on attenuated corrected imaging from a radiologist perspective. Something I think is useful at the outset is to get a sense of the technique used to generate the images and what possible limitations come from that. A diagnostic chest CT, for example, uses MAS settings, kind of the current, so to speak, of the tube and the CT scanner that are about 6 to 10 times greater than that of attenuation corrected CT. That means that substantially less photons are reaching the detector, so noise of these images will be increased quite a bit. The attenuation corrected images are also reconstructed at 5 millimeters slice thickness, whereas a diagnostic chest CT is typically at 1 to 3 millimeters. This talk is geared towards the analysis of attenuation corrected images, but I think it's fair to look at the question of whether or not the images should be reported. And there's different perspectives on that. So to give some insight to that, some researchers pooled data from several different nuclear medicine departments. In this report here, there were close to 2,000 patients. And of those, that were close to a quarter of them with a positive finding or reported finding from the AC CT images. And from those, with further review, about 3% ended up having clinical significance. And then looking even beyond that, only 0.2% had potential detrimental impact on the patient outcome if they were not reported. Another point of interest is that the rate that those findings were noted or recorded varied with the scanner generation, with the positive predictive value noted to be higher in modern generation scanners. Looking at some more data on this, another group reported a larger number of patients, close to 4,000, reviewed retrospectively, and these were found to have about a 6.5% of these patients found to have potential clinical significance with incidental findings. Looking a little bit deeper, the actual significance was thought to be 12% of those cases reported, 14 of them with malignancy. So looking at the positive predictive value, this was 17% for incidental findings and incidental malignancy at 8%. And to keep in context or keep in mind that the percentages that we're discussing here are of those patients with the tagged cases, not the overall patients. So in other words, 6.5%. So of that fraction, 17 and 8% were thought to be relevant, and then also the incidental neoplasm. So clearly, trying to work out, some of the nuance does take some thought, and that there's a fairly low positivity rate. And here, for example, is an opinion piece from an imager with experience in this area. So I wanted to at least bring to the table a consideration of should the incidental findings from the AC images be reported, and then with enough data or enough position to back up your stance, then hopefully that'd be useful going forward. So if a decision is made to report these images, we would really prefer to take a structured approach. And this so-called checklist approach we borrow from the aviation field, and it's very well known, really, I think, to everybody in medicine, in particular those involved in surgery or procedures. And this can be applied to our non-cardiovascular findings. As an initial step, we can include a field in the dictation template that is geared toward the reporting of non-cardiovascular findings. And I included this blurb at the end here about a good physician being similar to a capable accountant, more so than a brilliant scientist or someone like the character from the House TV show. And this was kind of inspired by a lecture I had my first week in med school, where one of our lecturers noted that, yes, training and intelligence are required, but the performance beyond that really has more to do with being ordered and sensible and thorough in how you approach your work, more so than making amazing deductive leaps. So with that in mind, taking a structured approach toward our image analysis, we can consider the chest as a series of compartments. And here's a sketch by our friend Netter. And we could start with the lungs. And in particular within the lungs, nodules are a major issue. If on the images provided, you're able to make out some description of the nodule shape, then that definitely holds relevance in that, for example, spiculation is known to be associated with neoplastic processes, lobulation potentially associated with a process such as a hamartoma. These are not fully reliable cues, but they're at least steps in the direction of improving our specificity. We can also consider calcification. Different patterns are recognized. Again, the degree of detail may be limited on our attenuation corrected images. However, if there is note made of a benign pattern, such as complete calcification, central calcification, lamellar calcification, etc., then that's definitely useful. Whereas some other patterns, eccentric or stippled, remain indeterminate. Nodule attenuation, also important, although we note that ground glass, for example, in other words, a nodule where there's change in the attenuation, but the adjacent anatomy is still visible, does not remove the consideration of neoplasm. And it's well known that certain neoplastic subtypes present with a ground glass attenuation. Further, we can characterize nodules and masses on the basis of size, with a cutoff point of 3 centimeters, basically. Then looking towards future steps, advanced tools for identifying and characterizing nodules will definitely play an increasing role over time. We want to use society-endorsed recommendations and standards when it makes sense or when it's suitable. For example, for nodule follow-up, the Fleischmann Society has some well-recognized criteria. And also understanding that these criteria are changing over time as people in this field or with focus in this area realize that different standards can kind of optimize which nodules need follow-up and which don't. Looking past nodules and masses, there are also more diffuse processes that we could consider. Here is a image panel. In the top left corner, we have a patient with pulmonary edema. So these reticular smooth thickening here with ground glass change, really fairly commonly noted in patients, particularly with cardiovascular disease. Next, patients with fibrotic lung disease may be identified incidentally, and here there's some distortion of the airways with some peripheral reticular change and even layered honeycombing. Other patients may have inflammatory airways processes or even septic emboli. The pleura, looking to the periphery of the lung or the interface of the lung and the chest wall, in a normal patient, the pleura will be very difficult actually to identify separately. But then when there is thickening or nodularity, as in this case here, then it becomes discreetly identified and really kind of leaps to our attention. So here we can see some nodular change and erosion of a rib, extension into the mediastinum, and then some old calcified and non-calcified pleural plaques, someone who likely had asbestosis complicated by mesothelioma. Extending our search out to the mediastinum and then the chest wall, with the consideration of lymphadenopathy, a fairly common consideration. In this case, we see what would typically be normal fatty planes in between mediastinal structure effaced in a patient with tuberculosis, where the adenopathy is even surrounding the vena cava here. Looking outside of the mediastinum and into the chest wall, we can consider using symmetry to help guide our analysis and reporting. And in this case, we can see the musculature surrounding the scapula expanded and changed in attenuation from right as compared to left in this patient with a fibrosarcoma. The bones, also relevant for our search pattern. And once enough cases have been sort of passed through our visual catalog, when there's change in contour or attenuation, such as this patient who has osteoblastic metastases, this will really become easier to identify and characterize with reference to a number of sort of normal cases to compare to. So circling back for final thoughts, the attenuation corrected images from a nuclear perfusion study are limited by the low MAS settings and thicker slice reconstruction. And the decision to interpret those images and the approach towards the interpretation should account for those limitations. If we choose to go forward with our interpretation and reporting, we really want to take a structured approach toward that, towards both identifying the findings and also our recommendations. I'd like to acknowledge my former colleague who contributed images to this presentation. Also like to acknowledge my daughter who contributed a sketch at the beginning of this presentation. And that's the end of my talk.